So you're basically tactfully telling the other person that you think that you'd like to do it a different way.
Yeah,
That
if I'm
you,
going to send care of this patient, if you're going to change this, you're going to
I have to be honest, that I think I've trained a lot of residents, and Sanjay aside, most of them I think like me. I don't want to overstate this. So, I don't want to, his testimony may be different, but
Jerry, because they haven't killed you,
yeah, they haven't
doesn't
killed
mean
me.
that they like you.
But I'm pretty sure it's not because I use kid gloves around them. I'm pretty open and honest, and I tell them, and I often change what they, make it clear to them.
Change it right back.
But I have to be honest that I don't think I'm nearly as good with colleagues. I think with
yeah, I was going to say, this is colleague to colleague.
Colleague to colleague, it's much harder. I think most of the time I go like, okay, as soon as this guy leaves, then I can do this right. But I don't say anything, and I don't. Part of the reason for this session is not to come up with answers, but to remind us that there are some things most of us probably aren't doing the way we should. And one of the things that I think a lot of people don't do the way we should is deal with difficult situations. It's always easier to just sort of fix it on your own, but it's much harder to confront people. And so that's what we're trying to talk about now is is it important, and when is it important, and how do you do it?
Yeah, and when as well, like you're saying, you do it in real time. Like that's always been very difficult for me. If I see kind of a gross mismanagement, I'm kind of like, I'm just going to assume care of this patient, start doing things correctly, and then maybe a day or two later, I'll try to find a very polite way to say, hey, remember that guy you signed out with appendicitis? He turned out having pneumonia. Isn't that weird? Like just sort of a very subtle way of handling it. Because I'm not good at that real-time confrontation with a colleague. That's very difficult to have that discussion in a positive light,
It's a small place where I am, so it comes back to the bite here.
I think you're right. I think most of us don't do it. Yeah.
By the way, this is a communication session, but if you're looking at the medical legal aspects of this, you do buy into it. When you're involved in the care of a patient, you take over a patient or you pass along a patient, you're involved in this situation. I've never seen the case where they just kick one guy out. Their job is to keep both people in. And you don't want to answer this question in court. Well, doctor, would you have handled it that way? If it was your mother, would you have let them do this or that? So going back to patient safety, when it influences patient safety or something down the road, I think you have to say a little something. By the way, half of you do this and it's wrong, is to, when you're passing on patients, you don't both go in and see the patient. One of the things in my career was I was going to see anybody who was given to me physically with them so we could review where we were. And you know what? As you go through that checklist in front of somebody, they say, oh my God, I should have done this or that, or you're right. I don't have to wait. That belly now is rigid. You need to call surgery. I think it's a technique thing, too, as to how we do it.
This is a little aside, but we initiated a process at our hospital where we would do just that. At pass-ons, you see all the nurses around the nursing station going through the charts. Well, the idea was the nurse who's going off duty brings the nurse who's coming on and say, this is nurse so-and-so, I'd like to introduce you to her. This is the status of the care of Mrs. So-and-so right now, and this is what we're waiting for, and Dr. So-and-so is going to come down and see her. But the idea of doing this only at the nurses' station, and the physicians do the same thing. You have to go in there. Can you imagine being an ER patient and a new doctor comes into the room and says, oh, your other doctor's off duty now? Is that the way to pass on a patient? No, you have to go in, introduce. This is an excellent doctor. He's going to be taking over for your care. He's only been disciplined 3 or 4 times in the last month. It's getting much better.
That we know of.
That we know of. Right?
But that gives them a sense of confidence. It's common courtesy, and virtually
I believe this
nobody does it.
I believe this completely, but it's really hard to do in a busy place. It's really hard to do. But I think it is important. I think it's a much better pass on. We're mixing up a bunch of different things. I'd like to go back to the other one in a minute, but go ahead.
This also addresses your issue that you're bringing with. One of the things we found on transfers, not all the cases, but the cases in recess, we should do one, and then we, oh, look at that, there's a pneumonia. So I think there's more of a discussion of a case in front of the patient.
They like it.
They like it.
So let's talk about, somebody raised the issue of a consultant if patients are being harmed. I want to get back to that in a minute, but let's stay with your colleagues. Do anybody have an example where somebody thought a colleague was problematic and it became a public issue and there was hell to pay over it? Became he said, she said, people arguing, you know, has anybody had that experience?
I mean,
Within the department, there are two people, you know, like somebody complains about somebody else, whether it's an appropriate complaint or not, whether it's over a medical issue or a communication issue or a personal issue, and the other person says, no, you're the one who's wrong. I'm not wrong, and, you know.
Again, of all those people I had to let go, I did have, this never goes well. Whenever you have a complaint of sexual harassment, and I don't care what it is, I've had every type of this, somebody's got to leave that department because it cannot go on with those two people working in that department. I had a young doc, came on, was dating one of the nurses. They broke up. He starts up with another nurse. Now the first nurse brings the action that he went after me early on. I mean, it was a mess. The nursing staff took sides with each other as to what was going on. It was awful. I had only one choice. This guy had to go to another hospital because it just would not work out. If you have those kinds of tensions, there's got to be some resolution, because if they're at each other every shift, it just won't work out.
Mark, you were going to say.
Many years ago, I worked for a surgeon, and he was actually very good. There was a surgeon from the other side of town, notorious for getting into trouble, and this was the fellow that always bailed him out. And I was listening in a discussion one day, and one of his colleagues said, "Look, Bob, why do you always bail this guy out? You know he's a shocker." He said there were two reasons. One, I do it for the patients. The second reason is, he said, I don't do anything about it because, you know, if people look closely at my practice over many years, they'll find unsatisfactory outcomes. And that's why I've never put in the formal written complaint about a colleague.
So I think there's a really important point there, which is to be humble, to not be arrogant and think we're perfect and the other one's wrong. But on the other hand, sometimes, you know, we all make mistakes, right? Every one of us has made mistakes, and that doesn't mean we're bad, it just means that we're human. But there are people who make more than their share, right? And where it's personal issues, where I do think we are abdicating our responsibility when we don't at some point get involved. And so some of you raised your hand and said you have put in some sort of formal complaint about a colleague, someone on staff. Anybody want to tell us about this? And did it go badly? Did it go well? What happens? Because that, you know, when I was very young and stupid, more stupid even, I did this once about a doctor who was, way beyond imaginable. I'll just tell you one story about him. There were a million stories about him, but there was one patient. I was an ER doc at the time, and he was an admitting doctor who was very important on the hospital staff. He was maybe the chief of staff, whatever he had. He admitted a lot of patients. And one day a patient comes in while I'm on, and she's in renal failure, and she's his patient. And it takes a while, but I figure out how she got into renal failure. This is a true story. But it was the straw that broke the camel's back. It wasn't, one thing. So when I went back and figured out how she got into renal failure, 2 years before, she had had a urinary tract infection. So he had started treating the urinary tract infection with 3 days of Cipro. No, that wasn't what he used. He used iamtobramycin. He admitted her to the hospital for cystitis, gave her iamtobramycin. When she went home, he had her come back to his office every day for another shot of iamtobramycin. For how long? 2 years. When I finally saw her in renal failure, she had, in the interim, had there were a couple of admissions for her. Now she was getting nauseated. Now her renal function was getting worse. And this time she came in and was in the ICU. And he basically killed her. She died. And he basically killed her by giving her a renal toxic drug every day for 2 years. So, I thought, well, I can't just ignore this, right? So I and a few other people, young people everybody knew him. Everybody knew this guy's crazy, he's terrible, blah, blah, blah. We made a complaint. And what do you think happened to that complaint? Any guesses?
Went nowhere.
Got
It
lost.
No, we made a fuss, we were stupid, obnoxious kids, so we made sure it went somewhere. And it finally went up to a committee, and the committee decided, and they had a big investigation, and they did actually punish him. And the punishment was that from now on, when he admitted to the ICU, for the next month, he had to have someone supervise the case. And then it went back to what it was. So I got a little cynical about the process. Of course, the hospital was most worried about this guy was a big admitter, so they liked him. And of course, there were all these threats at the time that all of us would be sued, the hospital and the people who wrote the complaint. So I don't mean the take-home message is we should back off, but this is, it gets really complicated. It can be really, you make the doctor you sent to the other hospital, could he have sued you, Greg?
I think it would be very tough the way our contracts are written, that we can sort of let you go for any reason at any time. He probably could have, but you know what? The last thing he wanted was that to be a public. Most people don't want public issues. I'll tell you a couple of attendings that I challenged. I said, why don't we discuss this at the executive committee? In the light of day, at 2 o'clock in the afternoon, they don't want to hear their problems discussed in front of their colleagues. Being in the emergency department for a lot of years is a great advantage because everybody's dirt on the entire medical staff, right? All the screw-ups, all the people who died, this, that, and another thing. I love it when I can remind them on the phone, he looks a lot like Mr. Smith. Remember what happened to Mr. Smith? And they say, all right, go ahead and admit him. Not a problem. Whenever you have these problems, remember, length of time in the emergency department, you do gather strength and power. No question about it.
I like number 12D. When you believe an ED colleague has a problem you think may be interfering with his work related to potentially age or cognitive decline. Have you had to deal with that at all?
Who are you again? What's your name? Have we met before?
Look, this end of the table, it's awful.
Anybody dealt with that?
It depends on the inside of the person, doesn't it? If the person says, look, I'm no good in a resource anymore. You guys, the very eminent director at a place I used to work, and he was quite...
Talk loud so everybody can hear.
I was just, when it was a really serious resource situation, he said, look, you guys, you're younger, you're sharper, I'm no good at this anymore, you take over, you had complete insight.
Well, this is
honest man.
This is one when the provider backs off. But what if the provider is doing shifts and his shift is just as difficult as your shift, and you notice that they're making some mistakes that were kind of obvious, kind of thing, and have you had anybody had to deal with that at all? Putting them out to urgent care clinic or anything like that? Well, I'm sure you will have to deal with it with time.
We need to prophylactically deal with this. The way to do it is to understand we're all going to get older. I think it's tough to wrestle drunks at 65 at 2 o'clock in the morning. I work with several groups. I do a lot of work with groups as to how they're going to mature it. That's a huge issue these days. Emergency medicine is not a quote-unquote cutesy young specialty anymore. We have lots of people who are getting older, and the smart groups have multiple options for their people as they age. Shorter shifts.
How many of you have something where age goes into schedule making?
You get out of nights at the age of 55 or something like that?
Or shorter shifts? Anybody have that as an option? Or
See,
Shorter shifts? Actually, shorter shifts should be worked by everybody.
Yeah.
You know, these guys that do 12-hour shifts in ERs that are seeing like 100 patients a day. I know a large group in Orange County, they went from 12 to 8s, and there's always this, oh, now I have to come more often. When that group switched over, it was like unanimous. We will never go back to 12s. It changed their lives. And I know, have any of you experienced the 12 to 8 differential, how it affects you?
Huge difference,
Huge difference.
especially in a busy.
Yeah.
Yeah, I mean, a 12-hour shift turns into a 15.
Always.
Well, you got to do your electronic medical record charting.
2 hours of charting and dispoing.
And it's not just your medical decision making. When on the first hour, I'm the nicest guy in the world. Thanks for coming. We love you.
Hour
it's great.
12?
We're here
Hour
to help.
12, you know what the answer is? When they say, I'm here to say, yeah, what's your problem? And you know what?
Let's hurry it up. Come on.
Let's go. That's exactly right. And as you get into that, it's not good. By this one group in Florida, they were about to spin apart because the young guys thought the old guys ought to work as many midnight shifts and this, that, and everything. And I said, by the time we got done, I had guys working 6-hour shifts. We had guys doing 2 a week in urgent care and 3 in the department, that sort of thing.
So
and their life got better.
So it seems to me, I'm a big believer in this, and it seems to me that it's pretty easy if you work in a big group. If you work in a big group, there's going to be a bunch of people at all different ages. And I think if I were 30 and somebody said to me, look, we're going to ask you to pull 1 extra night a month because these guys can't do it, we're going to give them a little break, but you'll get to the point where you don't have to do it, I'd be fine with that. If on the other hand, you work in a group where there's 5 people and that person doesn't work nights, that means we're all, it's a draconian effect. My God, you want me to do all this stuff? That gets a lot harder. So any of you in a situation like that, and how do you deal with it?
If I can expand as well, the Australian experience, once you reach consultant, you don't do night shifts. I'm amazed that.
Like, once you get to be a good doctor, you don't do night shifts?
Yeah. And then the other interesting thing is that the Australian, as you know, the Australian exam, the fellowship's only been around since the mid-85. So the guys that passed the fellowship for the first time, they're reaching towards the end of their careers. And George Breitberg stood up a couple of years ago at a conference and said, look, all of the first year of people that sat the exam, the amount of time that those guys spend on the floor actually seeing patients now is virtually zero. They can't sustain it, or they haven't sustained it. And isn't it a shame that all that experience, goes, because it's too hard. It's too hard to carry on being at the shop, continually. How's your chest pain, when did it come on?
So I personally, I worked in England for a while where it wasn't even the consultants who didn't stay overnight, it was the registrars who didn't stay overnight because they were too important. And I think that's crazy, personally. I think you need to get to a point where your senior people do everything. And you're not talking about 55-year-old, you're talking about 40-year-old. I think people at night need to have just the same care that people need to have in the day. You need to have a critical mass to do that. And I don't want to go into all the politics of Australia or this, that, or the other thing. But I do think that if I were czar setting up a system and you had the wherewithal, you had enough people, I would absolutely make sure that there was gradation of these physically demanding things so that as you got older, you did less of them. It's obvious to me that I can't do what I once was able to do. On the other hand, I think it's equally important not to make it draconian, where we don't do anything and you young guys do all the extra work. That's terrible. I think it has to be a graded thing. Maybe by the time you're 55 or 60, you're doing only 1 night shift or even no night shifts. But it shouldn't be like the more senior people get to lord it over the others, they get all the bad shifts. You do that, then you're only going to get misery. Everybody's going to be unhappy. But I don't think you then go to the other extreme where everybody does the same. That makes no sense to me.
In that,
I'm sorry. I had a colleague who was in a group that did the content nights. In other words, they did 1 or 2 nights and were guaranteed they wouldn't have to do nights when they were beyond a certain age in the group. And I think that was their way of becoming partners. Well, then financial things changed, and about 10 years later, back doing nights.
yeah, that's a really bad risk to do that. What about some of these other things? Do you ever any colleagues who cherry pick charts? And how do you deal with that? You get the back pains, they get the ankle sprains.
Yep.
Or they're really, really great doctors for that one patient they see today. What do you do? Do you do
Slow
anything
and
about that?
cherry picking charts.
What do you, it should, I mean, on the one hand, maybe they're not very, they would be really bad if they tried to see 2 people in an hour.
Yeah, well, the RVU bonus takes care of that. There's no question we have more productive and less productive docs. It's based on an RVU bonus, and those people who move meat get paid for it.
But a lot of places don't have that, Craig.
Yeah, well, then they need to think
That's, well,
about it.
that's very common now.
Yeah.
In the States.
Not, yes, it is common, but it's certainly not universal. What do you do? What do you do about somebody who's, you know, let's leave out the one who really isn't able to go faster. What about the one who you think, you know, they're on the phone all the time and they're doing other things and you're sort of stuck? Do you do anything about it?
Very difficult
does anyone
situation.
know such a person? Have you ever heard of such? Have you ever done anything about it?
I've dealt with it in a couple of ways. First off, in the last hour or so of somebody's shift, we allow cherry picking.
Great.
Okay.
In fact, you should even encourage it.
Yes.
You shouldn't be doing, I think that's a great rule. I don't mean to cut you off, but we should have it that in your last hour, you're not doing anything that you're going to have to stay later for. That's crazy. A pass-on's a bad thing. So if you know this case is going to go for 3 hours, the person at the end of the shift shouldn't be taking it.
Right, and that's what we do, of course, at least 50% of the time it is, you know,
Yes.
it's a ankle sprain, but it's because they passed out when they run.
Yeah, exactly.
Yeah. I don't want to let this go without a comment. We had one place where there was sort of a 9-hour shift. The first 6 hours you're in the department. The last 3 hours you're in urgent care, plus taking care, finishing up those patients that you had for the first 6 hours. It was like night and day because there was almost no pass-ons, and you knew that you were going to do some lacerations and this, that, and another thing. It was an excellent way of doing it so people got out.
You were going to
But
say.
otherwise, you know, the people who are jumping charts, I mean, you know, we have the electronic board like probably everybody else has. It shows how long the patient's been there, and and we put a lot of pressure on each other. If somebody picks up a chart that hasn't been there as long as, say, a less desirable chart, you know, then we'll say, oh, you know, I mean, we'll just point it out to each other. Oh, you missed this one. Oh, this one's been here longer. Why don't you take that one? And I'll take this one. Or the nurses will bring back 4 patients at a time. You know, look at each other and say, hey, I'll get these 2, you get those 2. You know.
What about somebody who you know is deliberately slow,
Well,
not working hard enough?
we have a lot of peer pressure in our group, and
Does it work?
we don't realize we have days and times where we're all,
Yeah.
you know, that happens. If it gets to be a, you know.
Okay, let me ask it a different way, a slightly different version. I know you all have this. The doctor who comes in late, 15 minutes late for a shift every single time. Not that, you know, you had a bad day, not that, oh, today the traffic was bad, but every time, oh, the traffic was so bad today. You know, like every time you're ever on, it's so bad. What do you do about that?
15 minutes, dock them 2 hours.
It's easy to say that, but do you really do it? Do people?
We have a colleague who's generally half an hour late, but I also know he's the sort of fellow that stays about an hour and a half after every shift. So when he's coming on, I always wear it because I know he actually doesn't put in. It's just he's not good at arriving on time. He's also not good at going home on time. So I wear it.
I don't know how the rest of you feel about it, but lateness is an insult to me.
I agree.
If I'm working hard, I don't care if you're the dumbest doctor in the world. If you're there 15 minutes early, you're my kind of guy. If you're there 15 minutes late, I don't give a shit if you're Jerry Hoffman. The bottom line, and I say that with great reverence. Jerry's a very smart guy, but you know what? If he's not there working when you're supposed to start, what he's just said to me is, I don't care about you. I don't care about your time. Lateness is not a good thing. And, you know, at the ASAP Management Academy, we had this panel of all guys who've directed ERs, and they say, what's the first indication that person's falling apart? They've now started to become late. Their depression, divorce, drugs, whatever it is,
I got to admit,
sit them
you know,
down and do it.
I agree. You know, all of the things you just said. If somebody comes in 5 minutes early, you want to kiss their feet.
Yeah,
I mean,
exactly.
It's so silly. It's what's the big deal? But it's like, you're early. Wow. You feel so much. It's so nice when somebody does that. When people are late, I agree with Greg. It's really disrespectful. It's incredibly disrespectful. There's no reason. I mean, cut everybody some slack. Yeah, once in a while, yeah, something happens. Once in a while, somebody forgets. Then you're supposed to be I'm on shift today? Oh, okay, that can happen. But if it happened 4 times, that's wrong. But on the other hand, I got to admit, I'm really bad at dealing with it. I just sort of, not for the reason Mark said, suck it up because that person does work hard. But I suck it up because it's really hard to complain about it. And we have people who, there's a couple of them who are always late and nobody's done anything about it. And I think it's wrong. I think we should do something about it. It's really hard to do. Have you guys done something about it? Have you ever fixed it? Do you have penalties for it? You come late, you stay late? What?
I think it's getting easier to deal with some of that stuff with emails now, because you can have that conversation electronically and not because that's kind of what our chairman does, is, if we start seeing, somebody's late all the time, he just sends out a mass email to everybody saying, hey, remember, this is when the shift starts, and we're not going to...
So it doesn't necessarily pick on any one person.
Right, he just sends it to everybody. And
Does that improve that person's behavior?
most of the time.
Because I can actually...
Well, then, you have to maybe send that email out again.
There's somebody on my staff who is a really good doctor, smart, does, works pretty hard in general. Is good to work with. When he's on, I'm on with him. It's nice. He's pulling his load. But he not only is always late, but he's proud of it. He sort of makes a joke of it. Well, yes, I come in late, as though that's acceptable. And nobody's going to shame him to do better. There would have to be a punishment. But I've never done it, and I don't know anybody else who's ever done it. It's just really hard. But I think it's wrong to let that behavior go away.
We take away the money. 15 minutes, we dock you for 2 hours. And you know what? That's straightened
That will
up
do it,
behavior
yes.
tremendously.
That will do it.
And by the way, everybody sat at the table, and you know that we're talking about 2 people out of 15. Everybody knew that.
So before you do that, should you have a staff meeting where you say, what are we going to do, guys? I mean, that's what I would say you should do. And then everybody agree. It's a lot harder for that person at that meeting to say, no, that's not fair.
That's not fair. Right?
I'm the one, and no,
I would like to get back to the slow doctor, because the slow doctors, they really do exist. It's not that they are lazy; they just don't have the necessarily.
They're lazy.
And they may not have the skill set to learn to move fast. And I think one of the things that can be done is that there are the doctors who are very, very, very efficient, and maybe pairing those up for a while, making it clear that it's not acceptable, honestly, to see 1.8 patients per hour in this department when all your colleagues are seeing this many, if you want to get the same pay, so that there are some skill sets that can be brought on. And there's no question that there are tricks to moving patients faster through the department, and maybe one of the quick, efficient doctors can mentor that other doctor so that you save their relationship with your group, you save their career,
I'm not
because
sure
nobody
that-
wants a slow doctor.
Yeah, but I'm not sure that's true, because I think the reason that people are slow has nothing to do with a skill set. I think it has to do with
Well, the decision-making processes.
yeah, how you
they
process
order tests.
information, et cetera. I think there
But
there are people you could make them go faster, but that would probably hurt patients.
As an example, there are some very straightforward things that people do that the nurses know, that this doctor orders these tests, and then after these tests comes back, he orders these tests, and after these tests come back, he orders these tests, and that is a recurring theme of how this doctor works, and basically, it's one of the contributions, the fact this doctor takes forever to see a patient.
If you have any question that this doesn't go on, the nurses will actually change shifts, not to be with certain doctors, because it drives them crazy. Some
Yes,
of them can't
but
move
let's
people.
go back. I have a question about Rick's proposed solution, because I think it's certainly, in some cases, you can make people go faster and they'll just do worse care.
Yeah, I think that, I can remember an issue, like this was a few years back, where our chairman decided the way he was going to deal with this issue was he was going to look at everybody's patients per hour and make that public knowledge, right, in the department.
And guess
your
what happened?
RVUs, right.
But the issue, and it was a little more complicated what he did, and he showed you where you sat in regard to everybody else, and how slow you were, how fast you were, and he thought that would really make the slow people go, oh man, I'm like a standard deviation behind the rest of the group here. I've got a problem, but it was actually the flip that occurred, where they were like, I'm really slow, but I'm delivering excellent care. These other guys are going too fast.
They all say
You know?
that crap.
No, but my point is that this is a really different problem to solve because there's a problem of insight and the physician's perspective too on what is appropriate care. Now, if you have someone who's like, I'm slow, I know it, I just wish I could do something about it, that's a different case than somebody who actually thinks they're going at the appropriate speed and everybody else is going too fast.
And
That's
in
a big
addition,
problem.
if you force me to change behavior, but I don't understand why I'm doing it or
That's
how I'm
right.
doing it, I may just give worse care. So this person may
exactly
say,
right.
you know what, I don't want to do sequential tests, so I'll order them all right up front.
Yep, 100 tests.
That's not
Yep.
good.
I think the idea is to watch the guys who have got it and ladies who've got it down in terms of their efficiency. There's a whole litany of things that you can do to facilitate getting patients through the department, and they're skill sets that are teachable.
I'm not
So
so
by
sure
the way,
they're
Rick and I have a friend who runs ERs in Washington State and Oregon and that area, Northwest Emergency Physicians. And I've sent him residents. I said, I've got the greatest resident we've ever had here. This is who you want. He said, Greg, I don't care how good they are. I want them out working someplace for 2 years, and then I'll interview them. But he says, out of the residencies, in residencies, productivity is not a premium. It's not taught. We don't expect it. We don't force them to move along. He says, I want 3 things. I want somebody who's had complaints with administrators, done this, had to be nice, had to move the meat, and had to say, I'm sorry a few times. Then they can come work with me. But he says one of the problems we have is that the residency programs, and it varies between the programs, some of them are not production oriented. By the 3rd year, you should be moving people along like an attending. I mean, they should be kind of coming in and getting going, and the information you get out of your supervisors at that
The
point in
attendings are
time
so
is
small
different.
that, yes, they
You
do
don't
it.
teach a 3rd year like you teach a 1st year.
Go ahead.
What you said is exactly right on, but I also think what Rick is saying is interesting, how you think you can teach these skills, because we can identify fairly early on which residents are going to fall into certain categories based on their experience. And I think it'd be very interesting to know what you all think are skills that are teachable to change that. I think obviously the more experience they have and the more book smart they are, the better it's going to be, but they have to also process their, each patient should be approached so that they can do quick decision-making.
Yeah, there's this whole literature about risk aversion, and I think there are people who are paralyzed, who really don't want to make... I think in general, to be a good emergency physician, in addition to knowing things and being smart and all that other stuff, the critical skill is the ability to spin a bunch of plates at once and the ability to make decisions with incomplete information. Not to be arrogant, we all see that. We're at the other extreme, where you just base it on nothing. That's terrible. But where you're able to say, look, I don't know everything yet, but I have a hard time believing that most of these are teachable things. Mostly, I think the reason people are slow is not something you can change.
Do you think you could change any of these behaviors for the most part?
I think-
Being late,
Yes,
being slow, being on the phone.
it's a good question.
Well,
Pissing into a-
I think you can if you incentivize. I think there are certain things that are in people's control. They don't want to work harder. They like screwing around. But you disincentivize it, they will change. But I think there are other things that if you incentives have nothing to do with it. They can't do it. They cannot be fast and good at the same time. And if you force them to be fast, they'll get worse.
They may need.
I've done this. It's in a small group of 6 of us, we've worked together for, 15 years, most of us. And it's the same people who have the same behavior
Do you think, though,
Shows up late.
do you think you could, would that change if
We'll never
you,
change it.
if
Nobody
it,
shows up.
how about if you disincentivized it enough? Would he change it?
Sounds like you've
Well,
got,
he does mostly just nights, so that's, that's
So
That's
you,
it, you-
you don't want to, you're willing to take the crap,
as
okay.
long as he shows up, I'm happy.
Right, but you could probably change his behavior if you were willing to, if by disincentivizing it enough.
Yeah.
That's very different than getting somebody to go faster than they're comfortable with.
There's some people who just,
They shouldn't be emergency docs.
And they're distracted by,
Absolutely,
and they focus on one person, they're oblivious to the nurse.
Absolutely.
So-and-so's lab, they're just oblivious, and then
Yeah.
they've been that way forever.
And they're not comfortable with indecision. Or
Uncertainty.
they're-
Uncertainty.
Uncertainty. And you and I have to be comfortable with a certain level of uncertainty.
They order tests, I don't even know what they test for.
I had a guy who was doing tests because somebody 2 years ago had been on vacation in Asia. He's checking him for malaria. and I thought, oh
Bottom
my,
line is none of them are really bad.
no, I hear you.
your
I agree with
your
you.
group is too small. Your group
I
is
agree with
like a family, rather than an ER group. Right.
The problem is, what I find with the slow outputters is they actually are incentivized to see less because they develop huge RVUs per patient.
Right.
Because they do unnecessary workups, and that just clogs up the emergency department. We tried a thing like that, we printed everyone's data every month, but we also include a number seen per hour, or number of patients seen per hour, and we tried to bonus on that a little bit, but still, they'll see less patients, but they have huge RVUs per patient. And so they get incentivized, well, look, I generate a lot per patient.
well, that's a conflict of incentives
Yeah.
at that moment in time because you realize the group or whoever it is, somebody did bill that, somebody did get some return on that. That's a much more difficult discussion and
I
decision.
take your point. It's a really important one. As long as basing it all on incentives, which sort of is attractive in some way. Okay, you don't see so many. Okay, you don't get paid as much. You see more, you get paid. But that whole notion has got a fundamental flaw, which is you get paid for all sorts of things that we shouldn't be doing.
And by the way, I think that there's a philosophy in each of the residencies which varies tremendously from we're going to work up every damn possibility for this disease because we are the bottom of the barrel. This is the place where decisions are made. When you get out and go to Keokuk, Iowa, nobody expects you to be working up, ankylosing spondylitis in the emergency department.
Although
They don't.
you know what they say is this is a teaching program, and that allows them, justifies them doing tests that may not be. It's a teaching program.
And
But
you
I
know
want-
what we teach
we're
them?
teaching
them the
wrong
Bad
thing.
behavior.
And I'm wondering what they're teaching them.
We teach them bad behavior.
So, yeah, so it's not shouldn't overpaint with a broad brush, but there is a lot of that. And I think it's even worse than that in other departments than emergency medicine. These are places see themselves as the Mecca where they find all the bad stuff. And of course, they do see the more complicated patients. They get sent those patients. But it's a crazy, crazy notion, and it's part of academic medicine, and it's a justified complaint. You were going to say?
Well, I was gonna comment on your guys building up the big bills, it's because you're running your butt off, seeing everybody else, and so you gotta have incentives that balance both. They're not able to do that if they were there alone.
Well, you're also implying that they're running up big bills on patients who don't need big bills.
Yeah.
That's called fraud.
That's called fraud.
But not if they say they needed it.
Yeah, how do you prove that? Everyone has a little different comfort level.
Sure.
And especially the younger guys coming up, you're really risk averse.
They're risk averse because many of them are taught by very risk averse faculty.
Yeah.
And if they're getting pregnancy tests on males, they're overly risk averse.
You don't? Yeah?
Yeah.
Well, I do think it is a concern because, I was hiring doctors for a long time, and this issue of their ability to move patients, you just wonder. I've heard that the RRC doesn't care about the issue of their productivity. That is not something that is measured or taught or is in the curriculum or cared about. And yet when you move into the community, that is one of the most important things. So we have a situation actually not universally, where physicians coming out of training aren't fully trained.
Absolutely, they're not trained about a lot of things. But I think what Cynthia said before is right, which is that I can tell 2 months into seeing them who's going to be which. I mean, there are certain things that are who they are as people. I tell the story often. We had 20 years ago, at least 20 years, maybe 30 years ago, we had a resident who came to UCLA to do emergency medicine after he had finished his medicine residency and an extra year as chief medicine resident at Yale. And he came with these glowing, glowing, glowing reviews. And he was brilliant. And he knew a tremendous amount. You know, he was an internist, chief resident, you know, had to do all these conferences. He knew all this stuff. And he was incompetent. He was completely incompetent. Not because he didn't know things, but because he could not be an emergency doctor. And in fact, he came to me, I was the residency director at the time, he came to me fairly early on and said, I can't do this. And what was his complaint? He said, you know, I'm in the middle of talking to a patient and they interrupt me. Like, oh, in an emergency, there's interruptions in an emergency? You know, but he had insight and, you know, we found him a different position. He left emergency medicine. It wasn't badness, it wasn't bad behavior, it wasn't stupidity, just the opposite. But there are people, there's a special skill to being an emergency doctor. And when we start replacing that with I do a million tests, you know where we are. So
By the way,
I don't think you can fix all that.
we associate names. Well, I'm a graduate of Yale, or I'm a graduate of this or that. Go screw that. I'd rather have a graduate from the residency program, the osteopathic residency program at Metamora Hospital in Michigan, than a Yale graduate. Why? Because I don't have to teach them how to be nice to the patients. And number two, they understand what they're there for and what they're doing for a living. And I think to a very great degree, we don't instill that in a lot of the training programs. I mean, if you're going off to be chairman at Harvard, that's one thing. Most people get jobs, and that's a totally different activity.
Yeah. No, but but let's not overstate this. You know, if this guy comes, if you get somebody who's highly recommended from a high-powered place, he probably has some skills. That doesn't exclude him from doing the other things. This person happened not to be able to do it. That doesn't mean everybody who comes from Yale can't do it. But in any case, the point is that very often it's an innate characteristic and not something that I think you can change.
Well, here's a sensitive, go ahead.
I was just going to say that we discussed how to not determine who's going to have a good throughput a few months into the residency, but before they're actually selected to come to residency, it's been trying to determine what questions to ask or to get a better predictive value of what this eventual resident will turn out.
Do you think you can do that?
But so I talked to my surgical colleague, because sometimes they see people come through in the training programs and they go, oh my goodness, this individual will never acquire surgical skills that we can become with. And they actually talked about having them, before they apply to the surgery program, they have to do a program, a suturing and something else that they actually have to get approval before they looked into having their set of skills approved by colleagues they knew. But again, you're relying on people who are recommending and word of mouth referrals.
I'm
Give an example where
I'm very, I'm convinced in my own experience that that we're terrible at picking beforehand, at knowing who's what. The recommendations, you know, you read a dean's letter, if it says anything other than this is the greatest medical student who ever lived, it means they have just killed 4 people. I mean, it's the greatest ever. The next thing is fabulous, which means they cannot speak the language. I mean, there's no such thing as average. Forget average. There's no such thing as above average. These are so grade inflated. You can never trust the letters. And those skills, I've had the best interviews with people who turn out to be just the opposite. I think if you see them, if they worked at your place, even that can be very misleading because they're on their best behavior. But at least that you have some idea of them. But I think it's a crapshoot, interviews.
By the way, you realize that the interview process is pretty much a sham. If you're not smart enough to lie to people for a day while you're there, you really are an idiot. And I was having this fight with Judy Tintinelli and Ron Chrome. I said, we ought to just stack them up. And unless it says, as Jerry said, something obvious, like,
Average.
he never stole anything from me, that sort of stuff.
That week.
That week.
Or when it says, call me.
Put them at the top of the stairs, push them down, take one off of each stair, and if you're such a damn good program, you ought to be able to turn them into a great ER doc. And she said, whoa, we've got to figure out this or that. And I said, Judy, you were just bitching to me, no matter how good you are, 2 days into the residency class, there's somebody who comes to you and says, by the way, I can't work weekends, I need this day off. These are adolescents who haven't grown up yet, and you didn't pick out those two who are going to be a pain in the ass for the entire 3-year program. Sanjay, is that fair, that there's always 2 guys in each class who you'd like to take out and hang?
Well, on the record, I'd say I love all my residents equally. No, I completely agree. I think it's very difficult to predict. Those of you who are sort of involved in training programs and things and can look back at your past year rank lists and things like that and then see at the end of the program who ended up at the top and who ended up at the bottom is remarkably different than how they looked up front. And like you were talking about earlier, it's nice when they have smarts and stuff, but then like Jerry said, that sometimes it can be too much or the wrong kind of smarts. They can just be very, very good at something, but not good at this specific skill set of what you need to be an ED doc. And I think that's incredibly difficult to tease out when all you have is a letter where everybody looks great, a 10-minute interview with somebody, and then a board score where, some of the best test takers aren't even the best physicians. So sure. I think, and if I'm not mistaken, aren't they doing a study on this right now at UCLA where they're looking at the rank lists and where they ended up 10 years later and where they are in their practices in the community and stuff.
No, he was ranked high for his example. There you go.
I rest my case.
I knew something was coming.
There were 2 people when I was residency director who I nixed from, we never ranked, for the following things. 2 different people. One person came in to the interview wearing jeans. And the other person came into his interview with me saying things like fuck and shit.
Was Billy Mallon interviewed there?
Billy Mallon.
And that fucker did this. And in both cases, they had fabulous records. And I don't really care whether you wear jeans or not, and I don't care whether you curse or not. That's perfectly fine. But I thought, these people have just shown me they have absolutely no judgment at all, no common sense at all. You come to an interview and you do that, you're way off. So there are some times where you get red flags, but most of the time people are smarter than that.
They might have turned out to be great.
I don't think so.
But there's all
They could be great somewhere else.
Yeah. Well, that's an important thing too, right? Because sometimes it could be right person, just wrong location. Because I work at a busy county hospital, and I have lots of residents over the years who I think would be great at another program, actually, where it was, like a more university type, a little more structured. They just happen to pick the wrong place, where not a lot of people speak English, and they, are really struggling with that, or they're struggling with the system. And
speaking of that,
those things are impossible to predict, because they are like, in the heart of it, everybody's like, I want to do the right thing. I want to work with the uninsured and do all this stuff. And then they get in there and it smells funny, and they're like, oh, wait a minute. This isn't what I thought it would be. And so even from the resident's perspective, I think it's very difficult to choose the right program, even if they're going to be a good doctor somewhere.
So while we still have a little time, I did want to talk about cultural issues for a minute.
Before you do that, you would think that being 2014, that there would be some kind of psychomotor test that could be given to somebody other than this crappy 10-minute interview and this letter that doesn't tell you anything.
The dentists have it.
That would ascertain your ability to, are you a rapid decision maker, and all of these kinds of things that we think make good emergency physicians, to see whether in fact somebody had those things, but there isn't, and it's hard to conceive of that this is the process by which doctors are chosen to go into emergency medicine, when there's clearly a wiring necessity that you be able to be wired to do this, and if you're not wired to do this, you're going to fail.
Yeah, so actually that leads to, just as an aside, why are we a specialty? What is special about emergency medicine? What makes us a specialty? What makes neurology a specialty? Everybody has, they have a special body of knowledge, right? There are certain things they learn that most other people don't learn, and they learn them, and endocrinology is the same thing. What makes neurosurgery a specialty? Is it the body of knowledge?
They know how to use a suction.
It's a skill, right? They have a manual skill. They spend 19 years being a neurosurgeon. They spend far longer than a neurologist. It's not because they know more than neurologists. They're practicing this skill. That's why they do this.
Do you know why it takes 19 years, Jerry? Because it takes 19 years to learn to say that this is a good result. Yeah.
So, but I don't think we don't have these special. So we don't have special manual skills that we can do that nobody else does, and everybody will tell you, well, they don't have a special body of knowledge. We have a little bit of a special body of knowledge, but not really that different. So what is it that makes us a specialty?
Time.
Yeah, so I think we have a skill as well. It's the skill we keep talking about. It's the ability to make decisions rapidly in the absence of in the presence of incomplete information. It's a really important skill to learn. I do think you can learn that. Everybody starts out, they can't do it, they don't know enough to do it. But the personal part, the personality part of that, I'm not so sure you can teach. The ability to be comfortable with making decisions rapidly. And I don't know, you could test somebody, do they have dexterity skills to become a surgeon? You could test somebody, do they have the brains to do to deal with complicated information? But this is a special skill. I don't know there's a test for how do you find out whether somebody
I
is...
bet you there's some video game that'll tell you the answer.
Well, that's why I meant to say that surgeons have discussed having their applicants actually do the simulator or the laparoscopic simulator and see how they.
But I think that's a much easier skill that they're trying to measure than we're trying
Yeah,
to measure.
absolutely.
Has anybody looked at, like, once you have a group of, like, extremely successful, like, you were exactly what we wanted, and you're successful, and you thrive in this field, and you do it very well. I mean, there's all kinds of psychometrics out there. Has anybody done psychometrics on?
Sanjay,
those
man.
people? 'Cause
Sanjay, you can do this, boy.
rates
You can do it.
high on an anxiety scale would probably be very good. It's something like that you have to just keep doing it to death, like.
If you want Sanjay...
Specialty of internal medicine.
Nobody's done that. And if we want Sanjay to do it or somebody else to do it, he has to have grant funding for it. And I don't know of any agency that's funding this.
Yeah, but I'm up for sale, so if people like to fund me, that's fine.
Do you have any issue about the differences between employed emergency physicians and contract emergency physicians in terms of their productivity? You know, I guess I kind of personally wonder, what is the motivator for an employed emergency physician to move? I know what it is for a contract emergency physician to move.
I hope that what you're suggesting is completely untrue.
That's why I'm asking it.
Because I think you're suggesting that the motivation we have to perform well in a social environment is money, and I don't think it is that at all. I think for most people it's not that at all. You want your colleagues to like you, you want to feel good about yourself, you want the patients to like you, you want to feel like you're doing a good job. I hope that as physicians our major motivation is not money. We're very well paid. That's a motivation for sure, but I would hope that the reason that people work hard, and the ones you look around you, the ones who work hard are doing it not because they think they're getting more.
Well, I'm asking it because I think there is potentially a difference in terms of an employed physician who is expected to get lunch and in fact needs to go to lunch because that's what the requirements are for people who work 8 hours, and versus the contract doctors.
I work in a place where there's
well,
no...
I'm not talking about any specifics. I'm just talking
No, but
about
I understand, but there are
categorically.
many places, nobody expects to get lunch where I work, even though nobody's getting paid by the number of patients they see.
Yes,
It's
but
not the environment.
I'm talking about the fact that there are more and more and more emergency physicians being hired by hospitals to be an employee, just like any other employee in that hospital.
Just like where I am.
Or community hospitals, lots of community hospitals. The physicians are employees, and basically they have rules about being employees. And what is the motivators for them to move? Is it strictly internally? Because I can tell you the motivators to move, if you're a contract doctor, is if you don't move, there's going to be a problem with you. You may be removed because you don't move patients quickly enough. That's not going to be an issue when you're an employed doctor or working in a hospital.
How many doctors?
What's that?
Why not?
Why not what?
Why not, if just because you're employed means you're not gonna be reviewed and your numbers?
Of course you can.
And your numbers are your numbers going to be an issue if you're an employed doctor?
Of course.
Well, the best example of that is if you look at the Kaiser program.
Kaiser, yeah.
Those are employed doctors, but they run on sort of a private practice model internally. That is, they do get reviewed. The other thing, you can't look at Kaiser as you look at other places. Kaiser is basically in those places where they have an excess supply of doctors. The West Coast of the United States. You guys don't have problems getting doctors.
Any
on the
Kaiser
West Coast.
doctors here? Well, that way I can be candid.
It is being videoed, right?
I can be candid.
By
I
the way,
think Kaiser doctors are terrific.
Before he takes off, I've got to actually catch a plane. It's been a pleasure. Thank you very much. Bye-bye.
Thank you, Gregory.
Good to see everybody. Pleasure is all.
Thanks, Greg.
I think I don't think we're superhuman. I think we're like anybody else, and we do like good incentives, and we like being paid and all that stuff. But I think the overwhelming motivation of people to be physicians, if all you really wanted was money, you're stupid if you become a doctor. It's much too hard work for the amount of money. You could make much more money just stealing people's money as a banker. You could do lots of other things.
You're giving doctors too much credit, Chief.
The reason, the motivation that most people have is they want people to respect them and they want to feel good about themselves. Most doctors. And the motivation to work hard is, I work amongst other people and I don't want them saying to me, you're the slowest one. When you do put up people's metrics, it has an enormous effect. Whoever is below on anything then starts doing more because they want to.
They defend themselves.
The only problem I have with the metrics now is that I'm seeing many patients on my shift that were seen the day before, by the kind of supposedly the fastest in the group, and now they're all coming back.
So can be problems, right?
They really weren't worked up, so is there a disincentive for bounce back? I haven't seen that yet.
Never. But again, to get back to Rick's question, I don't think the reason any doctor, or the vast majority of doctors, work is because somebody's going to fire them if they didn't. How many doctors get fired anyway? It's almost none. So that's not the reason. The reason is because you want your colleagues to like you. Most of us want our colleagues to think highly of us. And we also want our patients to like us, and we also want ourselves to like us. I think we're motivated much. Yes, you can change our motivation by offering us things and disincentivizing things, but that's not the primary reason why people are slow or fast.
I recently went through a situation where there's a contract fee-for-service position into an employee situation. And, I'm going to have to agree with you. I mean, I see no difference in the level of hustle that the doctors that I'm working with now as an employee situation versus, the fee-for-service RVU contract group that I was with a couple of years ago. I mean, everybody's in there, working hard, trying to get the patients, through as fast as they can, as safely as they can.
Of course, there were examples where hustle changed, and there's this long history of hospitals buying physician practices, which happened about 10 or 15 years ago, and now which is happening all over again. And when they looked at the productivity of physicians after the practices were bought, it went down substantially because they became salaried from when they were not, and that is a recurring theme that has occurred.
No, I don't.
Yes, it is.
No, that's not. No.
No. These are private practices of physicians,
That's outpatient practice.
outpatient physicians.
Tremendously different. So you're scheduling a different number of. It's not like you have the same waiting room and then you decide I'm going to only see 8 today. They don't have them in the waiting room. They're allowed to schedule less. They schedule less. That's very different than they're sitting there. I'm not going to see them because I have no incentive to work because I'm getting paid a salary. That's not how any of us think. I don't know that we have time there. I did want to ask one little question about sort of cultural issues in the department. In Los Angeles, we see patients who speak 150 different languages, and what's more, we see many, many, many different types of belief systems, healthcare belief systems. So I just wanted to pose, for example, an issue of the son says, don't tell my mom what the CAT scan showed, tell me. The son is from China or from Arabia or from somewhere. I worked in Japan for a little while on a sabbatical, and there you were never allowed to tell the woman. The woman was never allowed to be told what was going on. You were supposed to tell her husband or her father. And I did this big thing for the university there, where I actually had somebody playing the role saying, I want to know, the woman, I want to know. And none of the doctors we did this hypothetical thing, none of the doctors would tell her, because they were tongue-tied. They didn't know what to say, because you're not allowed to do that there. I mean, it's the culture, of course you're allowed, but the culture is, you don't tell the person, you tell the head of the family is always a man. So somebody comes over here and says to you, have you had this? Or somebody says, don't tell my mother. I mean, I've had it many times. So what do you do? So that's, we don't know that yet. So that's a critical point. You want to expand?
If you ask, if the son said that to you, and then you ask the patient, who is the mother, would you like to know? They said yes.
So I think that's the short. I've heard a lot of people say, well, it's in the culture, we shouldn't be arrogant and impose our culture on them. And I think that's true. If the mother doesn't want to know, she says, tell my son, that's fine. We shouldn't insist, she has to know. On the other hand, I don't think you can just trust the son. And I also think it's important to ask the mother or whoever it is outside of the presence of the person who's making that demand. Because there's tremendous pressure to say, oh, my son, tell him. Go ahead.
When we were in Australia, the same kind of thing. There's lots of immigrants for different forms, different groups. So for me personally, what I do is when I go to see the patient, if I can communicate with them, I establish the channel of communication. If they can't speak, if they can communicate with me, and they communicate through someone else, that's a different issue. So if they're competent and if they can make rational decisions, I will communicate with the patient. With the family in there at the time, the way I can establish who needs to know is I'll ask the patient, I'm happy for those people to be here when I talk to you or when I examine you. If the patient says no, I walk them out of the cubicle, and that's just about. So if they say yes, then I communicate with the family as a group, but I don't specifically pass on the message through the family unless the person can communicate.
Right. So I think it's really easy to mix up stereotypes and generalizations. The Japanese culture in ethnic Japan is you do this. That doesn't mean, that may be true as a generalization, but that doesn't mean you stereotype every Japanese person as that's what they want. I think it's really, really critical. We do deal with lots of different cultures, and I don't think we have the right to tell them what they might do, even if we don't like it, even if we think it's wrong. But we do, you have to find out first. That's
But
the
it
critical.
can put you in, like you can imagine, really difficult situations. I can remember a case I had just a couple of months ago, actually. Similar situation. His son was bringing in his mother for abdominal pain and was saying, just so you know, may help you as a doctor, she has metastatic cancer. It's all over her body, and she doesn't know. And like that was, sort of
That's
established.
helpful. That's helpful.
And she has a doctor, and they have decided not to treat this. That's what the son had decided, but the mom never knew she had cancer, didn't know. And he's like, so do whatever you need to do, but just don't mention it. Don't bring it up. And I was like, okay, that doesn't sound like an easy situation, and it wasn't. And we get put in those situations. And
So what did you do?
I didn't talk to her about it. I asked her, like you'd suggested, to see what she'd want to know, and I said, I know you've been going to the doctor a lot recently. I was kind of like hint, hint, wink, wink. Do you have any idea what's wrong? What's going on with you? And she said, no, my son says I'm sick and I'm probably going to die, and that's that.
Did
And
you specifically ask her, would you like me to tell you more?
I said, would you like to know more either about what has been going on with you or what's going on today? And she said exactly like what you had suggested about your visit to Japan. She said, absolutely not.
So I think
Rather
that's
everything
perfect.
go through him, but I was sort of like, whoa, culture shock for me a little bit still. But I, respected. I didn't find anything on that visit, luckily, emergently, that required me to disclose anything to her.
But
so
you
I
don't
didn't
have to
be in that
disclose to her
conundrum.
anyway. I think
But
that's,
it was still, it was a very sort of, for me personally, a difficult situation to be put in.
sure,
To always be
because it's so
cognizant of
different
that.
than what we're used to. Yeah.
That's right.
And that's what I was going to say as well, yeah. So that's a little surprising for two reasons. My experience has usually been when I say to the person, do you want to know? They say yes, usually, not always. And the other thing that was surprising is that she didn't know. The vast majority of the time, people know. And I remember when I first heard Elizabeth Kubler-Ross speak many years ago, so I'll give her credit for saying this, but she said how, and I've had this experience, she said, that same type of thing, the family's protecting mom from knowing and blah, blah, blah. She finally goes talk to the person herself, and the person says, the hardest thing about this is pretending to my family that I don't know, that I'm dying. Of course they know most of the time. But I think it's perfectly, as hard as it is, we have to get used to it. If that's what she wants, that's okay. But we also shouldn't just accept his word for it.